This is the Dental Up Podcast, brought to you by Keating Dental Arts, a full-service, award-winning dental laboratory. Each week, you'll learn tips and techniques from real-world dentists, bringing you in-depth interviews, motivating stories, current events, and sports. Here's your special host, Bob Brandon.
Welcome back, Dental Up community. My name is Bob Brandon. I'm filling in for Sean today. I'm actually the lab manager at Keating Dental Arts. Today our guest is a man I've known my whole life. He's a 1967 graduate of the University of Southern California School of Dentistry, who's been in private practice most of his practicing lifetime in Huntington Beach, California. Welcome, Dad.
Well, thank you very much. Thank you. I'm happy to do this. It sounds like it could be fun.
Yeah, thanks for helping us out. So each week, Sean interviews a wet-fingered dentist from around the country. Sometimes they're our existing customers. Sometimes they're new prospects. Sometimes they're dentists with, some new, fun, unusual ways of either treatment plans, or they have some tips and techniques that they want to share. So today, Dental Up community, we're going to speak with a dentist that's been in private practice for nearly 50 years. He's seen it all, done it all, seen lots of changes in the profession. So we're going to speak to Dr. Dale Brandon and get some of his thoughts on how the profession has changed and progressed over the last half century. So you and I were talking last week about when you graduated dental school, some of the materials or the material choices that were available. Can we kind of pick up and talk about what was available to you back in the late 60s?
Okay. Basically, for fillings, we did essentially amalgams on most all posterior teeth. There were some basic new composites coming out at that time, which were very, very grainy, gritty, but they were white.
Didn't polish
so
well?
Some people wanted those. Pardon?
Didn't polish well?
No, they didn't polish well at all. They were very, very, large particle size.
Were they more abrasive?
Oh, yes, much more abrasive. For the anteriors, we were using acrylics. We were using silicate cement. Silicate was great for anything small because it had a very nice fluoride release, so you rarely ever got redecay, but it also washed out. So those were pretty much and we were then beginning to use composites in the anteriors. But, again, some of the very rudimentary composites.
When did you see a big change in the market for materials that were available to dentists for more aesthetic type restorations, either direct or indirect? When did that take place?
I would say probably in the 1980s. And what I'm thinking about is when we begin changing from, a posterior tooth, you always put a gold crown if you had to put a crown on it, to the fact that you would then begin to, if you really want something more aesthetic, we can do a PFM for you. But pretty much the gold was still the reigning choice for posterior teeth.
Do you remember when the first lab tech approached you about PFMs?
Actually, I had done PFMs on posterior teeth actually from the very get-go back in 1968. So, I hadn't done many because the market was not there. It cost $50 more than a gold crown.
Oh.
And
now it's quite the opposite.
It certainly is. It certainly is. But I remember when I first went in practice, the price for a gold crown was $85. That included the gold.
Oh, wow. And
the price for a PFM was $135. So a lot of people go, oh my gosh, that much difference? Oh, no, I'll go with the gold crown. But so, times change, but you have to realize, the value of a dollar then and the value of a dollar now.
Sure.
So it, that all goes lockstep. But the fact that, the gold itself has increased so dramatically, that's what I think, kind of killed the gold crowns for one thing.
Yeah.
That you couldn't do them for what you used to do them for.
Composition and alloys, they've gotten better. They've gotten better in terms of marginal seal and malleability and wear properties. If you look through a catalog from either Argent or Ivoclar, for instance, you have so many different choices in terms of full cast and high noble restoration. So the variation in gold is pretty significant.
Yeah, well, that's always going to be there, I guess.
Yep.
So anyway, and then more recently, of course, we've seen the zirconia crowns come in, and e.max, and all of these others. So, it's an ever-changing landscape.
In your opinion, what has been let's start with the most aesthetic. What's been the most aesthetic material in your hands for your patients?
Actually, I like the zirconia-based, where, you've got your Keating Aesthetic, which is a very nice looking crown. I like those because you're not going to have any metal margin show anywhere. You don't have to put them as far below the tissue. You can put things basically at tissue height, and you're not going to have any aesthetic problems, where with a PFM, you still had to sink even that labial margin or buccal margin under the tissue, because you got a shadowing. Even though that was covered with porcelain, it was a very, very thin layer of porcelain, and you always got a graying effect. So I think the most aesthetic have been, since we've gotten away from the metal.
Yeah, absolutely. And would you say that it's allowed you to prepare the teeth a little bit more conservatively?
Oh, absolutely. Absolutely. Now you don't have to go below the tissue unless, it's demanded by either decay or fracture or whatever you have. You can keep it basically there at the tissue height, and the tissue likes that a whole heck of a lot better than you going down there with a burr and then sticking some foreign substance down there and leaving it.
In terms of the strength of the materials that we have available now, e.max and our KDZ Bruxer Aesthetic, and you're still using a lot of the original version of the Bruxer material, which we call the Bruxer High Strength. In terms of axial wall and occlusal reduction, would you say your preparation style has leaned a little bit more conservatively for those types of crown preps, or are you still just kind of preparing teeth the same way?
I would say I can do them a little more conservatively. I still think you have to have a certain amount of clearance everywhere. The thing I like about the Bruxer crown versus a PFM is that I think I read for nationally somewhere that 7 to 9% of PFMs will fracture, and we'll get this on a weekly basis. Somebody comes in, I broke something, and they fractured a piece of porcelain. Mm-hmm. And basically I tell them, well, here's the options. We can make a new crown, or it's on your upper second molar. Nobody sees it. We can smooth it down because your tooth is totally protected with that metal coping. But nevertheless, it's fractured, So, and I think I've only had one Bruxer crown fracture.
And you've been doing them for the last 3 to 4 years consistently,
I
can only remember one also. So I think that's a pretty good track record.
I think so too, and I like that. I can be, much more confident. We can put this in that patient's mouth, and it's going to stay that way, for a long, long time.
Yeah, and if we can continue and extrapolate on this trend, I think a lot of younger dentists that are just graduating, either recently or will soon graduate, they're not going to be faced with some of these issues that you've had to deal with over the last 50 years in terms of, aesthetics and porcelain chipping and porcelain delaminations and porcelain fractures and everything. What about in terms of the Bruxer, the KDZ Bruxer Aesthetic? And we did that for you on 7 through 10. What was your experience? Tell us a little bit about how you presented, when your original crowns were made, and the overall change in aesthetics that we were able to do on your own mouth.
Okay, now I fractured 8 and 9 when I was about 12 years old, And back then they put a little temporary crown on, and then when I was about 17 or so, I had to have something a little more permanent. And the dentist I was going to said, "Oh, told my parents, hey, you're in luck. I've got a young dentist that just came out of the Navy, and he's doing these new things." It was the PFM crown. So I had these put in when I was like 16 or 17 years old. And over the years, of course, 7 and 10 wore down. My lower anteriors wore down. And of course, 8 and 9 did not.
Yeah. They were porcelain on the linguals?
I think they were. And back in those days, that porcelain was very, very abrasive.
Yeah, large
particle size. So basically, 8 and 9 wore down all of the lower anterior teeth. So it was like I had these two giant teeth right in the middle of my mouth. It was like Bucky Beaver, because everything else was shorter now. But it all matched when it was put in.
Sure.
But over the years, of course, the years took their toll. And then when we had them all redone, I think we veneered the lower anteriors first
to build up the lower incisal plane to a nice level.
Correct. Yep. Correct. And then did the Bruxer Aesthetic on 7 through 10.
Do you remember what we did when we were evaluating facial aesthetics? When we took that, I remember one of the first photos we took, it was a relaxed smile, or it was actually called lips in repose. And we were looking at how much maxillary incisal edge should be showing. Do you remember any of that, or was that more for us technicians?
I don't remember any of it now.
Okay. So we took the photo. We took the first photo. It was called lips in repose, and we evaluated how much of your maxillary central incisor was showing. And what we did was we figured that we needed to move your maxillary incisal plane up 4 millimeters, apically 4 millimeters. You were showing, just like you mentioned, you were showing too much tooth. So,
right.
The first step was to actually decrease clinically your tooth length of your maxillary central incisors, and then build your lowers up to that level. The material that was used on 7 through 10 was the KDZ Bruxer Aesthetic. Do you remember that?
Correct.
Okay.
Yes.
Yep. And on the lower anteriors, we chose to go with e.max veneers.
Right.
And what would you say is the aesthetic outcome, the shade, the color match, the value match? Was it great? Is it acceptable? Do you want to redo it? What is it?
I think it's great. Personally, I just had a patient in today. It was an older patient. I mean, she's younger than I am, but and I had not seen that patient for several. I mean, probably 8 years, 10 years, and she was saying, "Oh my gosh, are those your own teeth? Oh, that's awesome. That's why I came back here to see you. I mean, because you always took good care of your teeth and so forth. So,
that's really cool.
Yeah, I thought so too.
What'd you tell her? Were you honest with her?
Yeah, I said, I said my teeth have had work.
Okay.
And she said, "Oh yes, happened. All of our teeth had work. That's not the original product."
Right. And I think what we see here, in the laboratory, and what our experience feedback wise from our clinicians is that the KDZ Bruxer Aesthetic, even though it's slightly weaker, it's a weaker version of our original zirconia. The aesthetic component is really close to e.max. Now, it's not e.max. Yeah. It's not lithium disilicate. It's not any of these newer e.max substitutes that you find on the market. But it really rivals the aesthetics of the original version of e.max. It's actually the LT ingot, the low translucent ingot. But and we've seen, here in the laboratory, we've seen a pretty big shift in our PFM restorations and our posterior full coverage e.max. We've seen a shift towards this KDZ Bruxer aesthetic material, because of these increased aesthetic qualities.
Well, yeah, and when you talk about decreased strength a little bit over the actual Bruxer crown, on the anterior, you're not going to need all of that strength that you're going to need on a posterior, like on a first molar.
Correct.
So you don't, unless the person gets hit in the face with a hammer, and then the breaking of the restoration is the least of their worries.
Sure, absolutely, yeah. And so you've also started to utilize some of our newer implant products, our Keating Custom Abutments, and formerly
Correct.
you would use a lot of the Atlantis abutments. What's been your experience with the newer the Keating Custom Abutment? I think we're now up to 5 or 6 cases.
At least that number. I've had very good luck with them. Honestly, I don't see a lot of difference between the Atlantis and the Keating ones. They've worked fine. They work great.
So clinically, in terms of seating the abutment, would you say that the accuracy of the connection is it the same as an Atlantis abutment clinically?
It's been a little easier to seat.
Okay.
On most cases. One case I had just a heck of a time getting the impression coping in. It was on like a lower second molar on a very elderly patient, and this was just I thought, oh my Lord, what's it going to be like when we have to now put the abutment in there and get it right? That would snap, and I just kind of my eyes opened and went, "Are you kidding me? Well, isn't this nice?"
Yeah, that was a good surprise.
Tighten this puppy down, and we're good to go.
Let's kind of go back and look at some of the technological advances that have taken place over your practicing lifetime. What's the single biggest advancement that's taken place over your career?
I would say in materials. Other than that, I mean, I don't use a lot of high-tech things in the office, as you know. Being 76 years old, I'm very happy with the way things have worked for a long, long time.
Well, there's something to be said for consistency. That's good.
Yes, there is, the tried and the true. So I don't use a lot of, computerized types of things in the operatory. So I know that these are the things that have been the latest changes in the last, 10 to 15 years at least. And, but I don't use a lot of those. So it's a little difficult for me to give an opinion on any of that stuff.
No problem. Fair enough. That's a good, honest answer. What about, so you mentioned materials. So are you talking like direct materials that you're using chairside, or indirect that your laboratory is able to provide for you, or both?
Well, both, really. I mean, the things that we use every day, are the direct materials. And I think that, some of the composites are now really changing dramatically, where they bond better, where they have fluoride releases in them. These things I think are great, because one of the original problems with direct composites was redecay, particularly on class 2s and so forth. And I think now with these fluoride releasing bases, with the fluoride releasing materials, with the fluoride releasing cements that we're now using as far as bonding the crowns on, I think these are all great things where you're going to have far, far fewer recurrent problems in the future.
Yeah, definitely. Let's hope so. Yeah, nobody likes to redo things, and we contact customers all the time when we get a remake, and I would say probably 10 to 15% of the time we're contacting a doctor and saying, "Oh, well, what's the reason why we're redoing this crown?" And literally 10 to 15% of the time, it's unfortunate. It's something that is just a part of this field. It's not a lab error, but we get the answer: recurrent decay. So they're cutting off a restoration and removing the decay that may have developed in the past 2 to 3 years after the crown was delivered. And it's very unfortunate to have to put that patient through 2 more procedures. Taking a crown off isn't very easy, especially with these stronger materials.
Amen on that one. Yeah.
Yeah.
And it's unfortunate also because it reduces the confidence that the patient has in both the practitioner and the field of dentistry itself.
Yeah.
It's like, wait a minute, I just had this done a couple of years ago, and now it's got to be redone. You know, we would like to say, hey, you know, put something in, and that's there for 15 or 20 years at least. I mean, I see crowns that I put in, you know, 45 and 50 years ago that are still there. I say, well, I think you got your money's worth out of them.
Absolutely. The only thing that's probably wrong with them is the color's too bright because the rest of the dentition is darkened.
That's very true. That's very true. But, you know, that's what you tell a person. Well, you know, look, the crown didn't change. You know, this is just you who
Right.
has changed over the years. And most people say, yes, I look in the mirror and I know I've changed over the years.
So tell us a little bit about your practice. I mean, I know a lot about it, but tell our audience, you know, where you're located. Tell them a little bit about the building and how close you are to the ocean, and tell them about your patients and the demographics of your practice.
Okay. Yeah, we are, as you just mentioned, we are in Huntington Beach, and we started, my first office was about 3 blocks from the ocean, and that was perfect. I could take my sack lunch down there at lunchtime and just, you know, admire all the wonderful looking people there on the beach
that weren't working.
And well, yeah, that weren't working. Yes. So that was great. And then we moved after about 8 years. We needed a larger office, so we moved up to a brand new shopping center they were building, and so we got a much bigger office. We went from 3 to 4 operatories. All the ops were bigger and decorated very nicely, very uniquely. And then that shopping center got sold, and so after 23 years, we had to move again. And so now we are in a medical dental building that's, it's only about a mile from where that second office was. So, you know, we have moved, we've stayed within about 5 miles of the original location, probably even closer than that. When I started, Huntington Beach was a tiny town. Now, of course, it's Surf City, well known everywhere and very crowded, very big. Some of these patients I've had for almost 50 years, and I've got 3 generations of so many patients or families. And I think that's really nice. I think that's the thing that, to me, makes the profession worthwhile. And I'll throw a little opinion in here where I'm afraid that the profession is changing that way. And I'm sorry that it is. I understand the whys, but I think it's unfortunate for the new graduates because they're not going to have this relationship with people that those of us old timers have had. In fact, many times I'll tell my patients,
without saying it directly, I'll say it for you. Are you speaking about the influence of corporate dentistry?
That's exactly what I meant.
Okay.
Yes. So, you know, and it's basically, I had a patient in today, I think it was the one I was talking about that had new teeth, or was talking about my new teeth. But anyway, she said, yeah, she had been going to some place. Actually, this was a different patient. But anyway, they go to some place because of her insurance and says, you know, they said, oh, well, we've got to replace all these fillings up here. Then we've got to do this. And now I think you've got a cracked tooth down here. Well, she had a big amalgam in a lower bicuspid, but there was no sensitivity, no sign of a crack or anything like that. But, oh, yeah, well, you've got to crown that, and you're probably going to need a root canal first, so we'll send you to our root canal guy. And she said, you know, it was just everybody had their hand out for money.
Yeah. Versus if she's
do it.
Yeah, and if she's in your office, that large amalgam with a potential crack, that's just something that you monitor every 3 to 6 months. And if it gets worse, then you tell her, okay, Mrs. Jones, this is where we are now. You know, we discussed this several years ago. Yeah.
Exactly. And you tell her, well, if you begin to have any sensitivity, because I've got a little bite instrument here, you know, which puts pressure on each cusp. No, there was no sensitivity anywhere. And she said, well, that's why I came back here. I trust your opinion. Yeah. And I think that's a thing that it's so important. It's very important to me anyway. And that these people trust me, that they like me, that I like them. And a lot of people will say, hey, Dr. Brandon, when are you going to retire? And I said, well, I could retire from doing these procedures anytime. I've done, every procedure, 10,000 times. But what I have trouble backing away from is, the personal relationships. And I said, so, when I do retire, don't be surprised if you walk in the reception room for your appointment with a new dentist and I'm sitting there. I'm just here to visit. That's all it is. I'm just here to visit. So, who knows? That may be exactly what I do.
I could see that too. Yeah. No, it speaks volumes about the human element of the profession. I mean, there's very few jobs in this world where you're that close up in somebody's face that, is still awake and is functioning and having to follow instructions and everything like that. And yeah, it's a people profession, that's for sure. And
absolutely. And that's one of the things when I'll have, young students who will come in and say, well, I'm thinking I'm becoming a dentist. And I say, oh, that's great. It's a great profession. And I said, well, why? And they said, well, I'm very good with my hands. And I don't care about that. And well, I'm good in math and science. I don't care about that. I said, do you like people? You're going to be working face to face, within probably 6 inches of somebody's face the rest of your life. If you don't like working with people, then I would strongly suggest you choose something different. But if you like working with people, this is a wonderful profession to be in.
Yeah, I mean, those other skills are absolutely necessary, but you're the way you interact and the way you care for people is certainly paramount. I think it's probably even part of the Hippocratic Oath that you have to take, before you're allowed to graduate. And
let me interject one thing here too, that I remember when I was a senior in dental school and we were, being, let's say primed to go out into the world. And I remember one of our teachers or the dean or somebody saying, well, now look, you're going into a profession. And a profession is charged with doing what is best for the individual you're dealing with. In other words, you're charged with doing the proper thing for your patient, not always necessarily the best thing for you. In other words, you should be treating the patient's mouth, not your wallet.
Yeah, definitely.
What was the essence of what they were telling us. And I think it's good advice. I understand that sometimes that's not the situation for one reason or another. But nevertheless, I mean, I think that's, those are kind of words to live by.
Yeah. I mean, then that, that person, if you're able to, save them money or offer them good advice, much more likely to be a patient for a lifetime versus, going elsewhere. So,
right.
So you mentioned a couple minutes ago about how you have, some younger patients in your practice that are interested in dentistry. What made you want to go into dentistry?
Excellent question. And I'll draw you an analogy here that, when you meet for no apparent reason, you meet that person that you're going to spend the rest of your life with. Okay. There's no reason that you were there, no reason that he or she was there. It just happened to be. Well, when I was in high school, I was a relatively intelligent young man and number 2 in my class. And so they figured, okay, this kid knows what he wants to do. Well, I wanted to be either a minister or a teacher because I like to talk.
I thought you said pharmacist.
Well, that comes later.
Oh, that comes later. Okay.
Yeah, that comes when I was in high school.
Okay.
Because I worked in a pharmacy, and so I thought it'd be fun to be a pharmacist. That was great. I liked it in the drugstore. My father wanted me to be an engineer, so I really didn't want to do that. High school counselor called me in and said, "Well, Dale, you're relatively intelligent. What do you want to be?" And so I said, I don't really know. I told her about these things. She said, well, think about it and come back. We'll talk a couple of weeks. Okay. So I did. And still, no, I didn't have an answer for it. She said, okay, a couple of weeks more. Came back in. No. She finally said, my husband is a dentist and he really enjoys it. go to the library and look up dentistry. Well, no, I didn't go to the library and look up dentistry.
Of course
but
not.
I was getting tired. Now, why would I do a dumb thing like that? And so I was a 16 or 17-year-old kid. So I'm getting tired of talking to this counselor. So went back in. She said, "Did you look up dentistry?" "Oh, yes, I did." "So what do you think?" I said, "That sounds great. Put me down as a pre-dental major." So that's the way it went.
Wow.
And
it all happened because you were too lazy to go to the library.
Yeah, pretty much. Yeah.
Great.
But
it's been a great career, though.
Oh, hey, like I said, it's one of those things that happens for no planning reason. It just happened, and it happened very fortuitously.
Sure.
And then I remember when I went for my interview at USC, and the dean of admissions asked, he said, "Well, now, where else have you sent in, application for dental school?" I said, "Nowhere." He said, "Nowhere?" And I said, no, nowhere else. He said, "Aren't you putting your eggs in one basket?" And I said, "Yeah, probably so, but I've got the applications for pharmacy school on my desk at home, and I really kind of think I'd enjoy pharmacy."
Oh, man, you said that to the dean of USC during your interview?
Yeah. So, I think the Dr. Rutherford was his name, the dean of admissions. He figured, well, we take him now or we lose our shot at him. So,
No kidding. Jeez.
So, most people sent, half a dozen different schools and so forth, but I didn't,
Wow.
So a lot of things just happened because of luck, I guess. I don't really think you should ever bank on luck, but every once in a while it works out.
Yeah. Wow. Do you have anything else you want to add before we sign off?
I think a little advice for the new dentists coming out and entering the profession. We've already talked about, treat the needs of the patient, not particularly your own, because if you treat the needs of the patient, eventually your own needs are treated. If you give them good advice now, they'll continue to come back, and that's going to, smooth your whole life. But enjoy your life, enjoy your work, and Confucius said, "If you enjoy your work, you won't work a day in your life," and that's the way I have felt about my profession. The other thing I think that our profession has allowed and does allow a certain amount of flexibility where you can spend time with your family and your kids. That
Yeah.
I spend a lot of time with you guys, coaching and everything, But if I were locked into a, 8 to 5 or 6 day a week job, I wouldn't have that opportunity. And so I think that our profession really allows that flexibility. The other thing, and this is something I've always tried to live by, is that remember that at the end of the day, there's only one face that stares back at you in the mirror. And you've got to be able to look that face in the eye and say, "Hey, you did well today." And that means you treated people fairly, you treated people to the best of your ability, and you did what you felt was right. And so I think that these are the little things that I would try to pass on to the younger graduates coming out of school.
Well, let me tell you this: you've passed that along to your children very thoroughly. I think Greg, Stacy, and I have always admired your work ethic and your integrity. With probably not ever telling you that, but we've always admired, how hard you worked and how you always were there for us, doing everything, coaching, helping with homework, helping with school, giving us advice whenever we needed it. And we couldn't have had a better role model for both you and Mom. So thank you.
Thank you for passing that along.
I hope our audience has learned a thing or two from a very seasoned 50-year practitioner, and Thank you for your time. Hope you have a great afternoon, and I will talk to you soon.
Okay. Thank you very much. And I hope that and some of this advice has helped those listeners.
Great. Thanks, Dad.
Okay. You're welcome. Okay. Bye.
Thanks for joining us on the Dental Up Podcast Show this week. Make sure to follow us on Facebook, Instagram, and Twitter, or search the Dental Up Podcast on iTunes for our weekly feed. Don't forget to visit KeatingDentalArts.com/promo for exclusive offers. Keating Dental Arts is a full-service dental laboratory, and we're nationwide. We'd love for you to send us a case so we can show you the Keating difference. If you dig what you heard, please leave a review on iTunes, and we'll be back next week.